I really appreciate that introduction. It's an honor to be here. I've learned a great deal from that, from participating in your ECHO project, and I always appreciate it. Thank you. So should I begin?
Yep, please go
Okay,
ahead.
awesome. So I'm going to talk about, I'm going to look at my timer. Substance use disorders and a focus on alcohol use in older patients. And there's a lot of things that we can go over with substance use, but I try to focus on some highlights, and I'm happy to answer questions at the end. I have nothing to disclose. Oops, let's see. No conflicts of interest. And I appreciate some of the slides are from Dr. Joseph Merrill, who is an addiction specialist at UW and the program director for addiction medicine. Him and I and Mary Davis, who's a current fellow, did a talk. So I borrowed some of the slides just to complement the talk. Now, I'm going to go over some risk factors, some protective factors, and some of the barriers to care when it comes to substance use. I'll give you a highlight on the important things to consider when you're treating elder patients, and also signs and symptoms to watch out for when you're considering substance use disorders. And then, of course, the next part of the talk, I'll focus on screening assessment and pharmacological treatments for alcohol use disorder. Understanding the issue, it's important to realize that the number of older adults with substance use disorder is increasing. In general, we do know that the geriatric population is growing, people are living longer. The baby boomers, their attitude towards substance use is different than prior generations. So they were exposed to substances more, and they have a much more open attitude when it comes to substances. So, 20% of the population is older than 65, but in general, the number of patients who have substance use disorders are increasing. So that's important to keep in mind. Also, the population is becoming more diverse. The non-white, the Hispanic population, they're growing, and you'll see more and more patients from those backgrounds. So good to keep in mind the diversity of patients that we have and their experiences. Substance misuse in the geriatric population, of course, can lead to multiple risks, and of course, risk of death is one of them. Many things, including medication interactions, cognitive impairments, increased risk of injury and falls, sleep problems, organ dysfunction. Those things can all happen. And then also, many providers and professionals unfortunately struggle to identify and provide treatment for substance use disorders. It is a challenging issue in the beginning to get your head around, but it's important to also not have any systemic stereotyping just due to age. That's basically ageism. That's the concept that I want to make sure we're aware of. There's definitely treatments, and there's ways to help patients with their substance use. Risk factors, these are some general ones. Social isolation, basically that can increase the chance of patients having mood disorders and not seeking care. Physical health, if somebody is having pain, high blood pressure, sleep, they're more likely to try to use substances to help and cope with their concerns. Mental health issues, I'll go over that later as well. Cognitive decline, including dementia, those are risk factors. Economic stressors, especially with the collective trauma that we've all been to. You can notice some patients, reverting back to using substances to cope with their financial stressors. Lifetime or family history of substance use, there's definitely some genetics involved. Availability of substances, believe it or not, there's just so much substances out there, and they're so much cheaper. So it was common for me to see patients during my fellowship who admitted to using substances from others, and it's available just down the street for them. So, and retirement, when it's not voluntary, that's a big stressor for a lot of patients, and that can be a risk factor. Protective factors, a lot of this has to do with the personal experience of patients and their likelihood to recover from stressors. So resiliency, having support network, having a partner, ability to live independently, access to basic resources, well-managed medical care. That's, I always promote, being a PCP is really important, and patients who have PCPs, they do a lot better. they get the follow-ups and the care that they need. Positive self-image, sense of identity and purpose are important as well. And of course, retirement when it's voluntary, you know, that's definitely a protective factor for a lot of patients who look forward to retirement. Barriers, negative attitudes, you know, whether it's the family or the providers, we need to keep that at check and realize that there is some bias that we may have, but that shouldn't stop us from treating patients, and we should learn and overcome those negative attitudes. Co-occurring physical and mental health, patients who have multiple comorbidities may not think about the relationship with substance use and not seek care. Denial of the problem. So if people are not seeking care and they don't think that it's a problem that they have, they're less likely to get the treatment that they need. Lack of social support, that also leads to less likelihood of seeing a provider. Accepting attitudes, so that has to do with some patients whose family members might say that, you know, it's okay for my dad to drink. This is his only pleasure, or my mom really enjoys that drink, or you know, that's a sort of attitude that unfortunately can go on for a while, and patients and the family may not realize that that's actually harming them, so they don't come out and seek care. Lack of knowledge, of course, again, not realizing that as people age, they have less body mass, less water content, more fat, so substances can stick around longer, they can have many more problems associated with it. Misinformation about treatment, that also has to do with that ageism and stereotyping, that thinking that the treatments are not going to work for elderly patients, or that they're not even there. So that's important to keep in mind. Cultural norms, as I was mentioning, there's more diverse population out there, and some patients, you know, their help seeking behavior is different, so it's important to keep that in mind too. Signs and symptoms of substance use, these are vague symptoms that can come up a lot of times, but any of these things, especially the ones related to mood and stressors, it's good to pick up on those things and at least inquire about substance use when patients come in with these complaints. These may seem very general, but any of these things could be a symptom of underlying substance use. And that's where I want to highlight the co-occurring mental health disorders. Really important to actually ask about and screen for these conditions. I've had many surprises when somebody comes in for anxiety and you inquire a little bit more, and you'll find out, you know, if they're using substances, coping with anxiety by drinking alcohol, maybe they're depressed. And it's actually really rewarding once you get to know the patient and why they're drinking. You know, the why of drinking is really important, and the co-occurring disorders, picking up on those and treating them effectively can really go a long way. There's screening tools for all of these, and if you can incorporate that in your primary care, and of course use your support staff to do this screening, that can really help with the efficiency as well. And now I'm going to focus on alcohol, because that is the most common substance use disorder in older patients. So about 50% of the adults 65 and older consume alcohol. 14.5% of them may have an unhealthy substance drinking, and about 53% of them have a hazardous or harmful drinking. Sorry. So the idea with this slide is that there's a tip of the iceberg. That's where, you know, patients who have alcohol use disorder, they may just be at the tip of the iceberg, and a whole lot of people, you know, 80% of people may be doing totally fine with their drinking. It's not causing any issues in their life, and it's totally fine for them to drink, you know, here and there. It's not causing any issues. But the ones who struggle with the use, it's really important to pick up on that. So when you do a screening, and this is, I know USPSTF recommends that we screen for alcohol use. When you do the screening as a universal, in a universal manner, you pick up on those things. So a common question I might ask is, you know, ask a patient, do you sometimes drink alcoholic beverages? And if it's a no, I inquire about past use, and if they were drinking in the past, you know, what made them decide not to drink. And if they say yes, you know, I ask about how many times the last year they've had 5 or more drinks in a day. And if they're over 65 or they're female, I ask if they had 4 more drinks in a year. That's a very sensitive and specific question that can tell you if somebody's having unhealthy alcohol use. That basically is a binge drinking episode. If they've had that, you have an 82% sensitivity and 79% specificity about unhealthy alcohol use. Another way of asking this is if they've had more than 4 drinks if they're male in a day, or more than 3 if they're female or over age 65 in a day, and if during a week if they've had more than 14 for males and 7 for females. There's some math involved here, but the key is just doing that first couple of questions to a screening would really be helpful. Diagnosing a use disorder. How am I with time? We're okay. So this is a key slide. I don't want you to memorize everything, but I just want to highlight the criteria and just tell you how some of these things are not always going to correlate with what your patients are telling you. So for instance, first of all, I just want to highlight the 11 criteria. I break them down into functional impairment, the first 4, and then the social impairment, then next 3, and then risky use, the following 2, and the last 2 is physiological changes. Just keeping the categories in mind really helps with when you're trying to ask these questions in a conversational manner. Now, in patients who are older, they may not have to use larger amounts or longer than intended, because even with small amounts, they may get effects that can be harmful. So that's important to keep in mind. Patients, the second criteria that applies to geriatric population, that's the same. The third one, spending a lot of time. Geriatric population, especially if they're retired, it may not seem like they're actually spending much of quality time to try to get substances. So that's a hard one to inquire about sometimes. Craving, there's no universal definition actually for this one. It's sometimes just asking about, if somebody has an urge to use substances, and that way you can find out if they truly have craving a lot that can contribute to their use. Next one's inability to manage commitments. Again, with the geriatric population, they may not complain of having any issues with their social life and managing commitments because they're retired or they got a lot more time. Continuing use, even though it causes problems in relationships, that can go unnoticed for a long time. And it may not come up that, the alcohol is actually what's causing their mood to change, and that's why they're not having a good time with their family, and they're always getting into conflicts. Giving up important activities because of use. Again, that's a hard one when somebody is retired and they don't have a whole lot of things to do. It may seem like they can't recognize that they're actually giving up a lot of quality time. Continuing use, even though it puts them in danger. So if somebody has other comorbid conditions, pain, anxiety, they may not notice that their drinking is actually harming their liver or their stomach, or they're having, bleeding ulcers and such. And the continuing use despite the physical or psychological problems, again, that actually goes hand in hand with number 8 with regards to the harms of use. And the last 2, the increased tolerance, in fact, in the elderly population, sometimes they have reduced tolerance because of the physiological changes. They may drink even less, and they're still getting a lot of harm from that. So it's not necessarily that they're drinking more and more as days go on. Withdrawal symptoms, that can be very subtle in the elderly population, and it could be more drawn out, actually. So I didn't want it to sound too complicated, but I just wanted to make sure we appreciate how it's not easy to just check mark these symptoms, and we have to really try to get to know the patients and find out if they're actually having a true substance use disorder. I try to do a conversation about unhealthy alcohol use, asking the patient to tell you more about their alcohol use. If they screened, yes, this is the next step that I would do. Try to ask about what are the good things about alcohol. Really trying to get deep down to the why of drinking, because that's going to help you with your treatment management. And of course, asking what their insight is about less good things about alcohol drinking, and if they've had any prior treatments, and again, listening for that reason to drink, whether it's coping with stress, pain, mental health, demonstrating curiosity and being non-judgmental. That's one of the pillars of motivational interviewing, and that's something that we can all benefit from any encounter that we have with patients, but just being there and listening to patients can go a long way. And making sure your goals are to have a supportive conversation and identifying those who have alcohol use disorder and letting the patient know that you're there to help them out along the process. Brief intervention, summarizing the pros and cons and try to link that to key medical issues can be really helpful. Asking permission to educate or advise, that's been shown to actually be a much more effective way of having conversation and telling patients about their use. I always make sure, even if I have an 18-year-old, ask for permission before I tell them about their cannabis use. So geriatric population, the patient in front of you, they have a lot of wisdom. You want to make sure you ask the permission and tell them what they really want to hear, and making sure you have a good therapeutic relationship. And of course, assessing readiness. So it's important also to find out what are the goals, what do they want to do with their drinking, whether they want to stop completely or have some drinks. Sometimes that does help you in figuring out the next steps as well. Now, I'm going to shift over to some of the pharmacotherapy. Again, I'm skipping the counseling section. There's a variety of things that patients can do before they are considered for pharmacological treatment. AA meetings, that has been shown to be really helpful. Counseling, CBT, there's a number of things that can be done, but I'm trying to cross over to some of the management that we should consider for patients who have moderate to severe alcohol use disorder. And again, focusing on the goal, whether it's abstinence versus reduction in heavy drinking, that's one thing to consider. And also acutely, if you're thinking about medication therapy, make sure that you're assessing the withdrawal risk. So if somebody has had history of withdrawal seizures, that's definitely not something you want to do outpatient treatment for. And you're going to make sure that they have a safe manner of having the withdrawals and treating them appropriately before you have them on a medication that's going to be used for a chronic condition like alcohol use disorder. Now, pharmacological treatments, I just put these here, but I can answer questions if there's time about each one of these. But the FDA approved ones, first line is naltrexone. Acamprosate is generally second line, and it's multiple times a day dosing, so it's hard for patients to remember to take it. Disulfiram, you definitely have to be abstinent if you're going to use disulfiram. That causes the buildup of toxic metabolites of alcohol, so they can't be drinking on it. The naltrexone or acamprosate, they can be started when patients are still drinking. The non-FDA approved, these are just 3 of them. There's more that have been studied, but highlights are gabapentin, which does help with post-acute withdrawal symptoms a lot. Topiramate can also be used, but there's sedation, risk of kidney stones, so it's a little more tricky to start that one. Peresosin, that's been used a lot, especially if somebody has PTSD as well, and that has been shown to be effective at higher doses. And this, I think, is a very important slide for primary care physicians, geriatricians. You got so many stuff that I was just talking about, but most of us will ask, I really don't have time. So how do we do this? Important to keep in mind, you don't have to do everything in one visit. You can start the conversation in one visit. I've had a lot of times where the substance use issue was brought up close to the end of the visit. So I would pick it up next time from that instance. I would make a note on the problem list, make a note, where we left off, making a phone visit or a virtual visit for follow-up before they come in next time, let's say, and making some plans in your notes, documenting where you want to go from here, and assess or writing down, how much you actually talked about things, so that you reduce the education next time and just focus on why you're wanting to make the changes and where you want to go from there. And of course, if you can have appointments in between office visits, like virtual phone appointments, those can really be helpful to just keep the conversation going with patients. So yeah, it's a pleasure to take care of patients and see them thrive once they either reduce their use or they stop drinking. Patients are very appreciative. This is the population who, again, may have ignored the problem for a long time. So if you bring it up and you start treating it, you'll get the feedback and make this a really rewarding work. I think that's all I have. Again, I can go over any of the slides that I can answer questions and go over any of them if you have any questions.
Thank you so much for that presentation. That was really, really helpful information for all of us. And I really appreciate that you mentioned how many things are packed into primary care and how to fit this in. That is great. Anyone who has questions, feel free to unmute. I don't know. It looks like Jesse had